Thank you very much for these beautiful lectures. And may I ask to the panelists to go to take a chair? And we have 15 minutes to try to answer to some burning question from the audience, please. Is there any question? Here? Micro, please. Over there. Okay.
It's a question to Professor Keck. With your aspirin exacerbation respiratory disease patients, your Sampters triad patients, what's your time course for FES surgery? If it's a primary case and you've diagnosed it preoperatively, what's your time course from the time of primary surgery to your aspirin desensitization? And postoperatively, in the immediate period, what medication do you put them on?
Okay, thanks for asking. Typically, the patients are advised to our department because of recurrent nasal polyps. So the typical patient already had 2 or 3 sinus procedures, but if the medical history is clear, even a patient after 1 sinus surgery because of nasal polyps is a good patient for desensitization. So, but most of the patients are coming to our department because of recurrent nasal polyps. So when there is the nose fully blocked with nasal polyps, first we do sinus surgery in our department in a quite semi-radical fashion to remove almost all of the problematic tissue of the sinuses, and then 6 to 7 weeks after surgery, the patient comes back for desensitization. This is our procedure. And there is an ongoing debate about use of, for example, Singular in pre-treatment of desensitization, but it's our observation that the reactions in desensitization are lower, and you may get false negative results in oral provocation. So we don't use a Singular in a pre-test manner anymore.
Thank you very much. Any other question on the audience? So I will make...
May I ask, Dr. Keck, you surely you know the concept of people from Mainz and Wiesbaden, Professor Mann and Professor Gozepad. They do believe that almost all the patients with nasal polyposis, they have subclinical forms of aspirin sensitivity, and they desensitized almost all the patients with chronic sinusitis, with polyps, with aspirin. What is your opinion?
Okay. This is only a hypothesis, and there are no clinical and scientific data underlining this theory. First, and this group you mentioned is performing maintenance therapy with 100 milligram aspirin daily. They published a study 2 to 3 years ago, and there was a very high dropout rate of the patients. So this is not a proven concept. Thank you.
Thanks. Any other question about the audience? So I will ask Professor Lopetin. When you have an apex root pathology, what should be the best? First to treat the teeth, first to treat the sinus, both together, because sometimes it's not as obvious to have a good coordination.
You mean the kind of periapical cysts
yes, yes, of course.
causing chronic sinusitis?
Yes, yes, of course.
Well, it's a very good question, because most of the patients they do not want to go to OR twice. So it's not a good decision to send the patient first to the dentist, to maxillofacial surgeon, to solve this problem, and if there is no solution for CRS itself, the patient comes to ENT surgeon for some minimal first procedure. So I think the best solution in this particular situation is to have two surgeons in one operating rooms working together. We fortunately have such an opportunity, because in one of the clinics where I routinely do surgery, this is ENT maxillofacial department. So we always have a good maxillofacial surgeon around who helps us in any case. But I don't need a maxillofacial surgeon if I only need to close the fistula, the anteralar fistula. That's why I need him only to extract tooth and to resect the apex of the tooth to remove the cyst. So it's a teamwork.
Okay, thank you very much. It should be perfect. Any other question about the audience? Maybe it's the last day. Professor Trimarchi, according to the therapeutic treatment, about medical treatment, in GPA patients, where will be the future, if it's maybe?
Actually, with the GPA patient, the treatment today is made mainly with rituximab when you can perform it. And it's very important to have the differential diagnosis in the patient, because you don't, sometimes happen that you visit patients that are treated for GPA and they are not.
Yes.
So I think that is a crucial point. What I said before regarding palate perforation that was not present in GPA is like a marker, because I visited once a patient that was treating as a GPA with a palate perforation. As soon as I look at him, I suspected that he was not a GPA. And the point is that sometimes you have to put patient like in a corner to make them admit that they are using cocaine, because in their psychological way of thinking, for them it's better to say that they have GPA, and so that they have a so huge damage because they have a very severe disease, and not because they are using cocaine. So I think that is crucial to find the right patient. And then for GPA, I think there is today nothing different from the use of rituximab.
Thank you very much.
May I ask a question? Matteo, do you close nasal septum perforation in cocaine users?
Generally, I don't close the perforation in this kind of patient. And I remember Bernard Spreckelsen, when they asked him what he was making with the septal perforation, he was telling, well, actually, when they are too small, I enlarge them so they are not making any noise. Generally, if the perforation is big enough and is not creating problem of epistaxis, I think there is not real a reason to treat them. When they're smaller, they make noise, and so we are closing it. But of course, after 1 year, 1 year and a half, they have stopped using cocaine.
And how can you make sure that they stop completely?
We make a hair analysis. It's the only way to be sure that they really stop, because the urine analysis is not enough, because after 2 days they have not any more cocaine in the urine. So the best thing is the hair analysis. And you can pretend to have it, because if the patient wants you to go to surgery, you can ask the patient to have the hair analysis, because if they have not, you don't go to surgery.
In my country, we fortunately do not have many cocaine users. Our people are searching for more cheaper options. But I had 2 or 3 cases of cocaine users with nasal septum perforations coming from abroad, and I performed surgery, and I cannot agree that patients do not suffer from nasal septum perforation. We performed a study recently, and we studied quality of life of the patients with nasal septum perforation, and the study showed that it deteriorated dramatically. So I think they definitely need surgery, and it improves their quality of life dramatically. This is my opinion.
Yes, generally I go with the closure of septal perforation when they have a septal deviated. So as I'm correcting the septal deviation, I'm also closing the perforation. But if they have not a septal deviated, if they can breathe in a normal way, I don't complain anything, I leave them and the septal perforation.
Thank you. Professor Tillman-Keck, how do you perform desensitization? I think it's always, in order to clarify to the audience, is always an impatient patient. Or maybe in some cases you began maybe in outpatient. In order to clarify to the audience.
I'm not the fan of performing desensitization, what is potentially dangerous for the patient, because you can provoke a severe hypersensitivity reaction, asthmatic, anaphylactic condition in the patient. So we always perform it on an inpatient basis. We have an appointment with the pulmonologist before to have an assessment of the pulmonary function, lung function test. If there is no sign for bronchial hypersensitivity, methacholine test is performed before, and then the patient is on an inpatient basis. He has an intravenous catheter for immediate drug application in case of emergency, and there's a continuous supervision of the patient, and there's availability of anesthesiologists and intensive care setting. I have a colleague in Germany who had a very problematic desensitization situation. She was a dermatologist, northern part of Germany, and she lost 1 patient during desensitization. So I only can advise everybody to do it with the best feasible impact of support of anesthesia, intensive care unit, and probably you won't need it, but I had asthmatic reactions during desensitization, and it's not only comfortable, but you are obliged to have the best support for the patient. Nihil nocere.
Thank you very much. I have no question to Professor Gevaert, but just a modest observation. I feel most of us, maybe not all, we feel guilty because we don't perform these studies, and we will take care in the future. Thank you very much. And just say my congratulations to the speakers, and we close this symposium. Thank you very much.